Morning, everybody. Thank you for coming to this month's Survivorship Lecture Series. Today, we have with us Dr. Tamara Hamlish, who is a research scientist in community engagement and health equity at the University of Illinois Cancer Center. She's a medical anthropologist with an MA and PhD from the University of Chicago, and she is PI for the CDC-funded Young and Survivor Network for Health Equity, a project aimed at enhancing support for women diagnosed with breast cancer before the age of 45. Before joining the UI Cancer Center in 2017, she worked on other projects that focused on strengthening access to community health. And her research projects focus on addressing disparities in cancer survivorship across the care continuum, from prevention, screening to palliative care and hospice. In particular, cancer survivor and co-survivor experience, doctor-patient communication, and the healthcare system capacity for building survivorship care. So today she will kind of talk about all these things, but primarily in the context of the YAAS, Young and a Survivor program, giving us an update from her previous talk with the Survivorship Lecture Series almost 2 years ago. So thanks, Tamara, for coming back and giving us an update. And go ahead and take it away whenever you're ready.
So thank you for inviting me to come back, and let me make sure that I have the right screen. I'm going to move this so that my face is not there. So I don't know. Oh, is this showing? Are you guys seeing the presentation, or are you seeing the notes?
We're seeing the presentation mode.
Okay, good. Thank you.
Oh no, I mean with the notes.
Oh, okay. So I'm gonna just there. Are you now seeing the slideshow?
It's perfect now.
Yeah,
yes,
good.
So I really struggled in putting this together because I have some of the same slides from the last time. I didn't want to completely repeat myself, but I also realized that not everybody was at the previous one. So there's a little bit of overlap, and I apologize for the repetition for those of you who have already seen this. This is just acknowledgement of the CDC funding for this work, and a graph that many of you are very, very familiar with. This is the SEER data on annual rates of new female breast cancers and annual rates of female breast cancer deaths. And there's that little dip at the very end in 2020, which I think is probably due to COVID, but annual rates of new female breast cancers has remained fairly steady, while annual rates of female breast cancer deaths have declined pretty steadily. There's been a couple little hiccups, but and what that means is that there are more survivors. So if there are more people getting diagnosed, or the same number of people getting diagnosed and fewer people dying, that means that people are living with a history of a breast cancer diagnosis or living with metastatic disease. So that's the first thing that is important. The second thing is, so what does that have to do with young women, and why do we pay attention to young women? The rate of diagnosis in young women is somewhere between 9 and 11% of all new cases are women under the age of 45, and between 40 and 45, it's like probably 7%, and the rest are the younger. So the younger women are even more rare. So it's not a frequent diagnosis, but it is it has a huge impact on the lives of young women. So the impact of the diagnosis is disproportionate to what it is in women who are older. So the American Cancer Society statistics, project 287,850 new cases. Approximately 47,560 will be women under the age of 49. And one of the challenging things about doing this work with young women is that there isn't always statistics available by age. And I'm going to talk about that a little bit more. It's the most common cancer in women 15 to 39. Women under 45 are underrepresented in research because the numbers are smaller. Estimated 30% or more of all breast cancer in young women is diagnosed in the few years after a woman has had a baby. And there's actually more and more research on this coming out, and that number is actually growing because the window of risk after postpartum is much more significant than people originally suspected. Compared to older women, younger women face more aggressive cancers and lower survival rates. And then within this disparity of age, there is another dimension of race. Black women under the age of 35 have rates of breast cancer 2 times higher than white women under the age of 35, and 3 times more likely to die than white women under the age of 35. In Chicago, there used to be really good statistics on the Chicago Health Atlas, and then they swapped it out, and now they've returned some of the age, but as you can see, it's from 2018. So since 2018, breast cancer mortality in women under 45 has increased by 33%, compared to 4% in women 45 to 64, and it's gone down in women over the age of 65 or 65 and over, reduced by 7%. So again, you see, even though it's a much smaller number of people, it is a much greater impact. 33% on 100 women is a large number. The disproportionate burden is in a number of areas. Financial toxicity. So if you think about the fact that younger women are less stable in their work, they've had less time to build up a nest egg. They have less financial literacy. They may have worse insurance. A lot of young people in general get the cheapest insurance with the lowest deductible, or with the highest deductible, because they are healthy and they don't anticipate having any health issues. And you get diagnosed with breast cancer when you have that kind of insurance, you end up with a lot of financial toxicity. Fertility is another big issue for young women, the loss of fertility due to cancer treatments. Sexual health affects women of all ages, but it is much more challenging to be a young woman who doesn't have a partner, or isn't married, or is newly married or newly partnered, and dealing with both low libido and low desire, and actual physical health issues. Psychosocial issues having to do with body image, dealing with the loss of body parts, and then general mental health. And then the long-term sequelae for a younger woman, if you're diagnosed at the age of 70 and you live until you're 85, it's 15 years. If you're diagnosed when you're 35 and you live to 85, it's 50 years of living with long-term sequelae. So it is, again, a disproportionate burden. The other place where we see a disproportionate burden is in diagnosis. So some of the recent research is showing that young age by itself, people thought before that it was just young age, that women weren't being, that the breast cancer wasn't recognized in young women, but in fact, young age alone is not an independent predictor of delay in diagnosis or worse prognosis. It's that they present with symptoms because there is no screening for women under the age of 40, and screening for women 40 to 45 is, as we know, a little bit controversial. 80% of young women discover the first symptoms on their own. So this diagnostic pathway through this project, we did some research on that, and I presented that at other places. Some of you may have seen that, but when you take screening out of the mix, what happens is that women discover a symptom on their own, or that other 20%, among that 20%, maybe half of them, their symptoms are discovered by a healthcare provider. They discover the symptom on their own. They have to make the decision to actually take it to their healthcare provider, explore, get an initial assessment, and this process can take a while. maybe because of insurance, maybe because they can't get time off of work, maybe they're afraid that their healthcare provider is going to say, oh, it's nothing, and sort of dismiss it, and they'll feel stupid for having brought it up. Whatever reason that there are delays in that. And then the next stage is that once they are actually assessed, and if there is some indication that there's an abnormality, then the action is pretty swift, that they go into evaluation, imaging, and biopsy pretty quickly, and there's a diagnosis. But that first part of it, there's a lot of churn there. Women, there's false negatives through mammograms. Mammograms are not super reliable for younger women with denser breasts. There's a lot of reasons why they're not, that there's a lag there between the exploration and the investigation stage. So there's a lot of reasons why it's a disproportionate burden, but it's one of the reasons that outcomes for younger women are worse. So as I mentioned before, then there's these other factors. So age is one of the vectors, race is one of the vectors, and gender is one of the vectors. So all of those things come together to create some pretty significant health disparities, many of which are preventable in the burden of disease that with changes in our healthcare system or changes in our approach could be prevented. One of the ways that has a lot of potential is by tumor type. So there's a lot of talk about Black women having higher rates of triple negative, and you can see in this graph, these are all under the age of 45. So triple negative is the second group, and it is much higher than it is in white women, but it's much lower than hormone positive breast cancers, where we have pretty advanced treatment. But one of the things that we suspect happens with young women, all young women, but perhaps young Black women especially, is that they don't do hormone therapy. Hormone therapy being a pill that you take at home. It's an oral therapy. And so it's much harder to promote adherence without really engaging with women about why they would want to take this drug, especially because they experience a lot of side effects. There's also a lot of, the Black-white breast cancer mortality rate disparities are a huge topic. But when you break them down by age, you can see that the disparity is much greater for younger women. So it doesn't achieve parity until 85, but the rate that huge gap that's talked about in all the news, that's for women under the age of 49. And that's when it shifts, is at the age of 49. So by not considering age as a factor, we miss out on a lot of opportunities to actually make changes to reduce that mortality gap. So that's kind of the background for this work, the CDC funded work. And as Dr. Mance explained, the purpose of this program is to increase the availability of supportive services for breast cancer survivors, young women with metastatic breast cancer, and their caregivers and families and their communities, as well, as we're finding out, as this project has moved forward. So what our response to the RFA was to leverage existing resources to build a sustainable collaborative platform that provides wraparound services. So connecting young women to each other, connecting young women to services, and making sure that the services that are available are appropriate and relevant to young women. So the first objective laid out by the CDC is to establish a network. The second is to develop innovative technology or technological opportunities for healthcare providers, educate and inform survivors, and then utilize patient navigation, community health workers to reach underserved populations. So what I'm especially going to talk about today is numbers 3 and 4, those are areas where we have some interesting results. We did not, and so we were funded in the end of 2019 and spent the first 6 months planning. And then as soon as we were done with our planning, we were in quarantine. So, and we did not want to burden healthcare providers who were already significantly overburdened at that time. So we really focused on the first one, the third one, and the fourth one. So our network is comprised of community partners. We have 5 what we call network partners, and about another 25 community partners, a lot of grassroots, small grassroots organizations, some national organizations. We have about 15 clinical academic partners, the survivorship team being one of our clinical partners. And then we had an expert panel, which was a group of young women who were diagnosed with breast cancer before the age of 45. And they were very actively involved for the first couple of years. And then there's been a lot of change, disease progression. One of our expert panel members has passed away. Another one had a baby. So there's just a lot of, these are young women with active lives, and some of them have had disease progression. So the expert panel was sustained for about 3 years, and then we started to see some attrition, and now we've moved to a more inclusive with community partners. So the expert panel is taking a smaller role. We have 3 women on our team who were diagnosed with breast cancer before the age of 45. So we have an internal external panel as well. So our focus has been, a recent focus, and what I'm going to share with you today is about resource and information needs. So we know that information needs vary across the care continuum. We also know that there isn't a lot of attention paid to that variation. So there is a huge amount of information that comes in at the start. When a woman is newly diagnosed, she gets, a big pink book, or she gets a big fat pamphlet, or she gets a ton of pharma produced material. Or even if you go on the internet and you look at some of the studies, they all look at that initial, because you come into a cancer diagnosis and you know nothing. So there's a need for information. But the truth is that you know nothing along this entire process as a learning process. And so we started looking at where else along the continuum there was a need for resources specific to that moment in time. We also know that the internet it's a wonderful invention. It gives us access to a lot of information. But it's also, that's the downside, is that it's a lot of information. It's a wide range of information. So it could be, women can find medical information, they can find support, they can find advocacy programs. There's lifestyle support. There's all kinds of things, but there's also a really large amount of misinformation. The next time I read that asparagus, if you eat asparagus every day, it will cure breast cancer, I'll probably punch a hole in my screen. There is massive amounts of misinformation, and for a young woman who's not very savvy about how to distinguish between research and non-research, it can be a really scary place. We've heard from young women that it's hard to stay away from the internet, but most of them really work to stay away from the internet while they're in treatment. And then there are some resources, some really good resources that are designed to meet the unique needs of young women, but there are not a lot of them. And young women have to be connected to those resources. So if they're not connected to those resources, if for whatever reason, wherever they're treated, if they're treated at a rural hospital that doesn't have a lot of resources and no one who specializes in breast cancer, they may never get connected to those resources. And they may just get that big fat book of 200 pages of information that they have to wade through to find information about how to make a decision about what type of surgery to have. So recognizing these needs, we pulled together a group of young survivors, including the expert panel and a few other young survivors. We had about 10 young survivors that were involved in this. We did a series of participatory design workshops to identify key questions, and then making sure that we were using the right language and identifying what the kinds of resources. So this is one of the exercises that we used in the participatory design workshop. It was online, and we gave them this grid and then asked them to plug stuff in. And this is for women who are newly diagnosed. We did 3 areas: newly diagnosed, completed treatment, and living with metastatic disease. And the result of that was what we call the I'm Still Me, Sigo Siendo Yo pocket resource guides. So, and I wasn't sure how to put these pictures in order, but that's a QR code up in the top right-hand side of the screen. And these are accordion style brochures the size of your phone. Each page has a QR code and has a curated list of 3 to 5 resources for each one of those topics. So those were the topics that were identified for newly diagnosed. And these are the topics that were identified for completed treatment. And these are the topics that were identified for living with metastatic disease. Some of the topics overlap, they look the same, but the resources within them are different, depending on where they are in the care continuum. So you can see here that the guide is propped up, and that QR code, if you scan that QR code, that will take you to an explanation of all 3 of the guides. It will walk you through, and you can click through and see what the links look like. But we decided to do something in real life on paper and not online, because what we found over the past 4 years is that many young women who are in under-resourced, underserved communities are not spending a lot of time online, or if they are, they're not looking for information on breast cancer. And that the way to get around that sense of being overwhelmed, or that sense of having to dig really deep for resources, say for women living with metastatic disease, is to hand them a pamphlet that they can use their phone. So they do eventually get on the internet, but they start in real life with a very small curated number of resources. And then and we picked those resources based on, again, worked with we did a workshop on this, and it wasn't the resources that were the most comprehensive. We looked for resources that were at a reading level that was accessible to someone would say an 8th grade reading level. We looked for videos. We looked for things that had diagrams and photos. We looked for information that was accurate, but also that was accessible. There are a lot of websites out there that have amazing information, but you really have to have an advanced degree to sort through and find, for it to be useful. It's just going to be overwhelming to most young women. So that guide has been in circulation, and I don't have the analytics for it. It's been sort of up and down. It's been sort of interesting to watch. And interestingly enough, it has been most frequently used. The most frequent use is by women who are newly diagnosed and women looking for financial assistance, work accommodations, and insurance information. So I don't think that means that that's where the trend is. I think that that's where people think to hand them these guides. So I think that wherever they're picking up these guides, whether they're getting them from their healthcare provider or whether they're getting them from a community-based organization, people aren't thinking about saying, oh, you've completed treatment, there's this really handy dandy guide that you can use, because we're still not accustomed to giving people resources at that point in the care continuum. And the same thing with metastatic disease. The focus is really on treatment. I mean, you definitely want to control the cancer for someone with metastatic disease. But there are a lot of other social determinants and other things going on that women living with metastatic disease need help with. They also need work accommodations and help with insurance and disability applications and all of those things. And that unless they find their path to somebody who helps them, they're not going to get that help. So I think that one of the things that we're learning is that finding places to distribute these and get them into the hands of women at the right point in time. So the other thing that we focused on, and we focused on this pretty, this has been a pretty significant piece of our project, and I've talked about this before, is the survivorship navigation. So we established a virtual learning collaborative to increase capacity for community-based survivorship navigation. So we know that screening and diagnosis, prevention and screening navigation is really effective, and especially in underserved communities. We know that it increases rates of screening and that it increases rates of people following through, getting evaluated and getting a diagnosis and getting into treatment. So knowing that, is it possible that we can use that same concept to do the same work with women who are at the time of diagnosis, and make sure that they get that community-based care and that linked community resources after they're diagnosed. So instead of just handing them off to a nurse navigator in the clinic, collaborating with that nurse navigator to provide community-based support for all the things that happen when they're home and that they need outside of the clinic setting. So we launched the pilot in January of 2021, and then just a couple of months, we just finished the first Spanish language navigation program. It's a 14-week series. Each week is 60 minutes, and each week includes a brief didactic. It's a 20-minute presentation on topics, and I'll share a list of the topics in a minute. And then, but the bulk of the session is the participants presenting de-identified patient cases. The reason that we do that is because when a facilitator or the teacher or whoever is leading this discussion presents a patient case, we present cases that end neatly. Even if they have huge issues and huge problems, they always end up tied up in a pretty bow. They're always successful. And we don't learn from those. We learn from the cases where there isn't a neat answer. And at the end of the day, there may not be a neat answer. The neat answer may be really complicated, or it just may not exist. And for a navigator working in the field, it's really easy to feel like they're failing because their clients are not able to get the services that they need. So it's really important for them to be able to have that conversation and know that they are doing everything they can and they're doing everything right to get services to this client, and that it's not them, it's the system or a resistant patient or something else that's going on. So when they present those cases, it's brainstorming, problem solving, and it allows all of those community-based navigators to bring all of their collective wisdom of having worked in the community for however long they've done it to bear on those problem solving. This navigation program is in collaboration with UI Health, community partners, and other CDC grantees. We've had facilitators, we have guest speakers. It's been a really wonderful experience. So this is the curriculum. I hope you guys can see this. And it covers a whole range of things. The idea here is not for them to become 100% proficient in every single one of these topics. It's for them to have enough familiarity with that topic to be able to say to a client, oh, I know a little bit about clinical trials, and it's something that you should explore because X, Y, Z, and let me connect you to somebody who can help make that happen, who can share that with you. Or as happened to me recently, I met a woman who told me that she had, a large number of family members who had cancer, were diagnosed with stage 4 cancer, and they had been tested and they were BRCA positive, and that she was petrified and didn't know what to do, so she didn't do anything. And so it was an opportunity to just say to her, you don't have to get tested, you don't have to learn that whether or not you have the mutation, but sit down with a genetic counselor and have that conversation and understand what your risks are and understand what it would mean to get tested. And if you walk away from that conversation not wanting to get tested, at least you're not sitting here petrified that you don't know. And that's exactly the level of information that we want them to walk away with. So we talk about sex and intimacy, which is always a very popular topic because it's hard to talk about that. And the statistics for oncologists and healthcare providers who talk about sex and intimacy with female patients is appalling. I don't have the statistic in this slide deck, but it's something like 80% of men with prostate cancer are asked about their sexual health, and something like 20% or less of women with cancer I asked about their sexual health. So it's something where women suffer in silence, and giving a community health worker the tools to have that conversation can open up a door for a woman to have that conversation with her provider, or to find resources, community-based resources that will help her along the way. We talk about genetics, we talk about insurance. People keep wanting us to add more, but we want to try to keep it to 14 weeks. So we're considering adding special lectures that people can come back and just do a one session lecture and then catch up on their cases. So we've trained 110 participants from 70 different organizations. The majority have been from community-based organizations or rural hospitals, small hospitals, community-based hospitals, or even we've had quite a few people from Northwestern, but from the Northwestern satellite, McHenry County, other areas, and rural cancer centers. So that's been the majority of participants. The majority are serving urban populations or suburban populations. So Chicago and the greater Chicago area, about 14% from downstate Illinois or other rural areas, and then small number who are online and cover a national audience. The name of this role is varies a lot depending on, I'm sorry, I'm going to put my headset on because that is going to.
Tamara?
Can you?
No.
Can you hear me now? Okay.
No. Yeah.
So I don't know if I have to do something to change this. Anyway, so we do a survey at the beginning and the end, a pre and a post survey, and these are the results of the survey. So I'm going to walk through the individual results and then I'll talk about what some of the larger implications are. But we asked them about their practices. So we asked them if they provide information on cancer or cancer treatment, if they link clients to medical or clinical care, we link clients to clinical supportive services, genetic counseling or testing, community supportive services, practical help, emotional help, healthy activities. And as you can see, there's not a lot of change. They start out, in the high 2s, mid 3s, on a 5-point Likert scale. And, the link to community supportive services is the only one that went over 4. Not a lot of change there. The biggest change was linking people to healthy services. So the other, we also look at their self-efficacy, and that's, how they feel about performing all of the things that we
that we train them to do. So an overall assessment of client needs, understanding the basic components of breast cancer diagnosis and treatment, educating others about breast cancer and breast cancer treatment, identifying medical resources, identifying supportive services, explaining how clinical trials work, linking survivors with services that are appropriate for their diagnosis and personal circumstances. And I say that because in the beginning, we asked them about what the biomarkers are for the breast cancer, and a lot of them don't know. And then as they learn more about the specific kinds of resources that are available, they learn to ask those questions because it gives them another set of resources that they can bring to bear for the patient. How to facilitate or support communication with healthcare providers and families, work collaboratively to address their needs. And the last one, which is, the train the trainer, service a community on breast cancer survivorship. You see this, the average was 1.
Hey, Tamara, you're breaking up.
Questions that we ask them as a barrier to navigation.
Yeah,
Okay.
your connection was breaking up. Oh, I think we lost Tamara for a minute. We'll wait for her to log back.
Yes, I'm back.
Ah, maybe a better connection.
Just have to. My screen again. And their knowledge or connections to cancer survivorship resources and services. I'm getting that. So they're not facing a lot of barriers in terms of having time, having support, there are barriers in having resources in their community, but the biggest barriers that they were facing were or that were modifiable with this training is their knowledge of cancer treatment, cancer, and their connection to resources. And what I think this tells us is as community health workers, as health ministries, as volunteers, whether they get training or not. That first set of questions about practices, they're doing this work, and the work doesn't change whether they're trained or not, which means that we need to get in there and give them good evidence-based support so that when they do the work, they have the right tools and the right information. And that is through their own, through the survey, that lack of knowledge is the biggest barrier. I think that it demonstrates the importance of getting this kind of a training program in place. I will say that when we started this training program, I was a little bit hesitant to do it because there is no reimbursement. So for women who are working, or for women, and that's 98% of the people, we had one man in this program over 5 cohorts, 110 people. But for the individuals who are doing this work, most of them are doing it either as volunteers, or they are on, it's a grant funded, they're not paid well for this work. It is, right now in the state of Illinois, it will be reimbursable, but it is not currently reimbursable. A little bit about patient cases. So what we saw, and this is now, it's going to take us back to the I'm Still Me, Sigo Siendo Yo guides. Most of them are connecting with patients right after diagnosis, within 6 months of diagnosis. So most of the cases, almost half of the cases, are within 6 months of diagnosis. Half of the cases are people who are in progress and in progress for treatment, and the second highest number is not yet started treatment, so preparing for treatment. Disproportionate number of young women in this group. So even though the number is smaller than the other groups, it's high based on that figure that I started with of 9 to 11% of all diagnoses. It's predominantly white women, but close tie for Black women presented as cases as well. Again, early stage, a lot of women with stage 1 disease, a lot fewer with metastatic disease. And I would say that partly that comes from, we don't connect to those women. They don't connect to the organizations because there aren't resources for them. And so we're not going to connect with them in the typical ways that we would, that those navigators would connect to patients in the community. And then predominantly English with a small number of Spanish speakers. However, with the Spanish language cohort, we will definitely see more of that.
Dr. Hamlish, we see this section, just so you know.
Oh,
It's showing the notes. If that doesn't matter, it's fine, but I'm just letting you know.
so now are you seeing them?
Now it's like presentation mode.
Okay, so it's swapped. Thank you. So the next steps, upcoming activities with YAAS, we're launching our 6th English language and our 2nd Spanish language cohorts in September. If you know people who are interested in that training, please reach out to us and let us know. Word of mouth has been pretty successful in promoting those programs, and they fill pretty quickly. But I have connections, and if you know somebody who really wants to do it, I think we can squeeze them in. We're launching a new program in a couple of weeks, Community Champions, and that is to build those grassroots community organizations to build awareness of breast cancer in young women. So what we found over the course of the past couple of years is that, a lot of those really small grassroots organizations just don't recognize young women, and they're not serving young women. And if you think back to the very beginning, those young women are dying at a much faster rate, partly because they're not connected to services and they don't have the information that they need to stay in treatment, to get the proper services they need to prolong their life. And then we're doing a series connected to this of Leaders in Breast Health Equity, which is a series of lectures on topics that, again, to train leaders in the community to be able to deliver the same kind of information. So our first one is in August, and it is with Triage Cancer to talk about open enrollment. So to train community leaders in supporting their communities in getting to use open enrollment to get insurance, to understand how to pick their insurance, to know what they're eligible for. And if you know someone who is interested in that, again, it's a train the trainer program. Please let us know. I think that is scheduled for August 28th. And then I just want to say a thank you to the YAAS staff who does 99% of this work. Talia Holtzman-Castellan is the project manager. Nikki Malazarte is the outreach manager. Joan Alcazar is our outreach coordinator. And then we get tremendous support from the Cancer Center. Miriam Ahmed is our grants administrator. Erica Seltzer does our IRB and compliance stuff. Courtney Colvin and Deanna Belendi in communications have been a tremendous support in helping us get the word out about things. And Courtney actually designed our logo. So that is it for YAAS. I could talk for another hour about it, but I know that we're low on time, and I want to be able to answer questions if people have questions.
Great. Thank you, Tamara, so much for that update. I remember seeing the emails about the VLC kind of coming out and coming. It's great to see the data coming out of that and really helping with providers and everyone. I see it really. Do you have plans for expansion of this program too? I can see this almost being like a national network type of thing, right?
Yeah, so we would love to do that. We're looking for funding to do that. I mean, that's, as always, funding, because we can't do it with the staff that we have now. But
Yeah.
I mean, it is a pretty intensive lift for the facilitator, because there's a lot of hands-on engagement to keep people engaged. By the end, people are, they're it's like being in a class where you get to know your classmates. We limit it to between 15 and 20 people per cohort, so they know each other really well. Everybody has to present. So yes, we would love to take it national. So if anybody has suggestions of funding sources for that, thank you, Dr. Razine.
Yeah.
She had recommended a funding source, and I'm still waiting to hear from them.
Good. And yeah, I don't know if they might be of any insight, but I'm almost envisioning, I know there's a clinical cancer community group of practice for City of Hope with genetics. And I kind of going through the City of Hope training, it's kind of similar. I'm like kind of hearkening back to that because it's a weekly and there's a cohort going through it, and everyone creates a large, widespread across the country kind of network. So I wonder, I can try to hook you up with, I know I need to hook Betty up. Betty was here. I need to hook Betty up with them too, because they might be someone that might have some ideas or something you could bounce off them on the educational front. So, because that would be stellar, and that would be a great network to build out.
Yeah, especially in states where CHWs, there's reimbursement for CHWs. Then you're training people who are actually going to get paid to do the work. I mean, I have to say that we have our attendance for these, it's 14 weeks long, and it's on a Monday or a Tuesday night at 6 o'clock, and attendance is almost 100%. I mean, we have very, very low attrition, with one exception. Our second cohort, after quarantine was lifted, it was really scary. Like there was just a lot of really serious illness in that group. But other than that, people just don't drop out. They stick with the program.
That's great. Yeah. Cool. Anyone? I know Betty's probably chomping at the bit. You're here and I'm thinking about you. What are you saying? Thinking you with the City of Hope work. Anyone else have any other questions or comments? I know Betty's in a lot of the same arena with different programs and stuff, so I thought she might have some comments or questions. But anyone else, this is great work that you're doing, Tamara. And I know the lecture series too is helping to fulfill some of your necessity for the CDC grant and everything too. So anything we can do to help.
Well, I mean, the lecture series is actually a perfect example of, when we started this, our goal was not to just continue to produce new things, but to leverage what was existing. I mean, we don't need to create a competing survivorship lecture series, because most of the topics that are covered in this series are relevant for young women. And I mean, I have to say that this lecture series in general has a tremendous sensitivity to young women. So it's a perfect fit, and it's an existing resource that we can just sort of then pair with this grant work so that we can promote the lecture series to our constituents and also, come here and talk about young women.
Yeah, definitely, definitely. And I might call on you, Talia, and or Joan, and or other YAAS team, trying to work towards getting CE credit for this, so we can get more people involved in these sessions and these discussions and teach more folks about these disparities and how we can help our patients the best we can. All right. What else do we got? Pam, Neha, any comments?
Hi guys, can you hear me?
Yes.
Yeah, great. Thank you, Tamara. The work of YAAS is just incredible, and this is so important. And I agree. Turning this into like a national initiative would be great. And thinking about, like Debbie mentioned, connecting with the City of Hope program. I think they were NCI funded. I'm not sure if that's continued, but there are like training. I would be interested in exploring how they are continuing, have they sustained their training, and think about similar mechanisms. So like connecting with Kathleen Blazer or others that are there would be, I think, really great to do it. We'd be happy to help you make those connections. So thank you for this. Excellent.
Yeah, no, I think there's definitely, what we found, maybe there are pockets that I don't know about, but when we started this, I thought, oh, we'll plug into an existing curriculum. We did not find one survivorship navigator curriculum in the country. The George Washington has a cancer navigation program, and it has probably some survivorship components to it, but it's a real different skill set to do prevention and screening versus survivorship. And some of the people who enrolled who came from the prevention and screening side of things, thought, oh, I already do this. And then it's like, oh, it's a whole different set of questions and resources. And you really have to know about cancer because people are scared and they're going to ask questions, and you have to be able to provide accurate information, or at least be able to point them in the direction of accurate information. So, I'm a big proponent of survivorship care, and I think this is a really huge piece of it, to be able to make that bridge between the clinic and the community, because there are lots of resources in the community that probably don't get used as much as they could, because people just don't know how to find them unless they're at a cancer center that points them to those resources.
Yeah. I wonder, have you kept up a discussion with Dr. Susan Hong? Maybe you can bring this into the VCU network.
Oh, I hadn't thought about that. Yeah, I haven't talked to her about it.
Because she's expanding the kind of paradigm we've kind of been practicing here, that we've kept with since she set this all up. So she might be a great person to expand this program with, to start over there. And Dr. Robert Wynn would probably be all over this, right? I already saw you have Jen Stewart on your speakers list. So it's a perfect fit.
Yes.
Yeah, and Tamara, related to that, we are thinking about writing an R25 to train providers in survivorship, but maybe we could expand this, right? It could be a sort of a provider and a navigator training and utilizing some of those mechanisms.
Oh, that would be fantastic. Yeah, I think that, like I said, the data, the data has been shocking in the what it points to there, that like they're going to do this, which is, I've done a lot of this training with providers. I did 10 years of training with providers in the ECHO program, and providers do not go outside of their scope of work. They stay very narrowly. So when they get a new skill, it does expand their scope of practice. But for these folks, their scope of practice is just whatever. And if you talk to them, they say, oh, I do whatever anybody asks me to do, because, if there's a need, they're out there in the community, they feel that need. If it means taking care of kids while somebody's in treatment, if it means picking up groceries, if it means you know, connecting them to Immerman Angels, whatever needs to be done, they just step in. They do not have, you know, a narrow scope of work. So getting them really solid information so that they're out in the community with, you know, accurate and reliable information. And they themselves recognize that. And that's why I think they're such good attendants, because they know that they don't want to be out in the community saying things that are not necessarily accurate.
Exactly. Yeah, and you're right. It's so different. It's like, you know, teaching providers about survivorship, you know, which I've been doing since I started here too.
Yeah.
And what we do in our clinic, it takes a totally different mindset, totally different approach and view on things. And people are really surprised when they like get into it and they're like, oh, this is survivorship. And because it's a different beast. I mean, I want to get into doing some more like just personal research or for like what programs and what exists out there at other medical centers, because sometimes a patient or something, I try to reference them like, oh, what kind of services are there in Denver? And so it's definitely I mean, yes, Pam humped off. It is
Yes.
one. And so everyone, again, thank you for coming, and thank you, Tamara. I'll send out the slides. Send me the slides, and I'll send out the presentation recording once it's ready.
Okay. Thank you, everyone.
Okay, bye.
Bye.